Hello and welcome. This webinar is a core part of Care for the Homeless's public education efforts, in which we facilitate collaborative discussions that tackle critical issues such as healthcare access and its intersection with homelessness. We would like to thank the National Healthcare for the Homeless Council for co-hosting this webinar with us. They're wonderful partners. This is yet another example of their partnership with us and us with them. And we'd particularly like to thank our sponsor, MasterCard, for their continued support of our education and policy webinar initiatives. Homelessness remains an urgent and complex public health crisis in the United States. Healthcare for the Homeless programs, or HCH programs, play a vital role in addressing the intersection of homelessness and health by delivering comprehensive, accessible, and trauma-informed care to some of the country's most at-risk populations. This webinar will explore the evolution and impact of HCH programs, highlighting their role as both a safety net and a catalyst for broader systemic change. Participants will hear from frontline providers who witness firsthand the health outcomes improved through these services and learn how HCH initiatives not only offer medical care, but also serve as a gateway to housing, stability, and recovery for participants in the program. Attendees will also gain insight into the ongoing policy and advocacy efforts that sustain HCH programs and the urgent need to protect and expand these lifelines. Our goal today is that you will walk away with a deeper understanding of how holistic healthcare is a cornerstone in the movement to end homelessness. In terms of the logistics for this afternoon, we will begin with an introductory presentation on healthcare for the homeless programs by Nathalie Interiano, the Director of Policy and Advocacy at Care for the Homeless. Then we will have a panel discussion on the impact of HCH programs. Following the panel discussion, we will get an update from Barbara DiPietro from the National Healthcare for the Homeless Council on the federal landscape and the impact that policy decisions will have on both patients and the organizations that provide these vital services. At the end, we will have an opportunity for questions and answers. Please submit questions via the Q&A function that is on your screen. Before we get started, we'd like to get a sense of who is attending this afternoon. Please take a moment to choose the role that is displayed on your screen. A little survey instrument has just popped up. You're welcome to choose more than one. Nay on our team will end the poll after a couple of minutes. And when the percentage appears on the screen, take a moment to acknowledge the highest ranking occupations, just to give us a sense of who is participating this afternoon. Nay will then pull down the poll, and we will then thank all of you and launch right into the webinar this afternoon. So thank you very much. So as we can see, quite a number of healthcare providers, homeless service providers, probably some overlap there. Concerned citizens, that's wonderful to see. Advocates, of course, we're delighted that advocates have joined us this afternoon. Some academic participants and people with lived experience of homelessness, perhaps the most important category in this list. So thank you very much for joining us today, and I will turn it back to Nathalie.
Great, George. Thank you very much. All right, so we're going to bring up the presentation. Perfect. Thank you very much. Thank you all for joining us. My name is Nathalie Interiano. I'm the Director of Policy and Advocacy at Care for the Homeless. I'm going to walk you through a bit about the history of healthcare for the homeless programs and our impact. And then, as George mentioned, we'll then move into our panel discussion. So I'll go to the next slide, please. To give you a bit of understanding of how healthcare for the homeless programs started, it certainly goes back to the 1980s when there was a really significant spike in people experiencing homelessness. This was as a result of several things that were happening at the federal level and local level. There were steep cuts to federal programs, there was very high unemployment, there was a decrease in the affordable housing stock, the deinstitutionalization of mental health care, and those numbers have continued to rise and have remained high ever since. So the origins of the development of the federal HCH program, HCH means healthcare for the homeless, so you heard me use that term pretty often, is closely tied to social and economic drivers of homelessness. Next slide. Now, before we talk, it's really important to sort of think about what the link between homelessness and health is. The experience of homelessness has well-documented long-term consequences on the health and well-being of individuals. Health problems are also a cause of homelessness. People experiencing homelessness have higher rates of chronic diseases and live on average 20 years less, depending on the chronicity of their homelessness, than the general population, the US population. Unhoused individuals need specialized care to address very complex health needs and a delivery model that can reach them consistently. So on the right here is just sort of an example that we have that compares the rate of chronic conditions for people who are housed versus those that are unhoused. And as you can see, the difference is stark. So I'll point to hypertension, 50% in the unhoused population, housed population, it's about 30%. Depression, about 50%, or mood disorders, about 8% in the housed population. Substance use disorders, same thing. Diabetes, it's twice what we're seeing in the housed population. So these are really important sort of metrics to keep in mind as we're thinking about the necessity for these services. Next slide. Just a bit about the history of how healthcare for the homeless programs were created. In the 1980s, as the number of people experiencing homelessness grew, the mainstream healthcare system was really not equipped to appropriately address their needs. So in 1983, there was a funding opportunity for early demonstration projects to provide healthcare to people experiencing homelessness. And in 1984, 19 cities received funds to establish healthcare for the homeless programs. One of those demonstration projects was in New York City with Care for the Homeless. And what's really important from what happened then is the data that was collected. This is the most expansive that was available at the time. The data collected from these programs firmly established the significant health disparities that people experiencing homelessness were living with, and confirmed the ability of well-designed programs to respond to the needs of a very marginalized population. And so through the years, we got some more funding for these programs. And in 1997, the Healthcare for the Homeless programs became established as a federal initiative to specifically serve folks experiencing homelessness, authorized under Section 330 of the Public Health Service Act. Next slide. Thank you so much. In terms of the model of care, there are several things that are integral to the HCH model. First, it's a compassionate and persistent outreach, an emphasis on reducing barriers or removing barriers to care, an understanding of the complex needs of the individuals served, the need to develop trust and respectful relationships, which is incredibly important, the whole person approach to care, and the delivery of comprehensive services by a multidisciplinary team, which you sort of see some of those here at the bottom listed of what that team could look like. In the model of care, we recognize the impact of trauma on our patients' health and integrate this into our understanding of our care models. Client-centered services are incredibly important because we are providing services to folks that are many times turned away from traditional institutions. And so down at the bottom, you see the workforce includes both medical and non-clinical staff, physicians, nurses, dentists, psychiatrists, social workers, case managers, community health workers, peer specialists, etc. So lots of different people working together to address the health needs of the individual that we're trying to provide services to. Next slide, please. In terms of our models of engagement or our service delivery, it is a core belief of healthcare for the homeless providers that everyone is entitled to high quality healthcare, regardless of how and where they choose to access it. So the goal of all the models of engagement that I'll go over in a little bit is to build relationships and in order to build trust and to reduce barriers to access, essentially meeting people where they are. We hear that pretty often in the work that we do. So the HDH programs that we're talking about today can be one or a combination of all these models, which no one program is the same. They all utilize sort of different tactics, but in these different buckets. So I'll really quickly walk you through what those look like. An on-site clinic is a standalone health center that exclusively serves people experiencing homelessness or the broader community, or both. They're essentially a one-stop shop to address the health needs. So you're going into a traditional sort of healthcare setting where they're providing services specifically to this population. The second is co-location of services. So these are health services that are embedded with other homeless services. So for example, in shelters, soup kitchens, meal programs, drop-in centers in New York, things like safe havens. And this reduces barriers to access. So one of the really important things here is that folks don't have to travel to get services. They're already there. Also with this concept of a one-stop shop, because you could be, say, going to get a meal and then also going to get health services. So this is also a really important model for us. Outreach, it's an essential component in building trust in communities. What usually happens is that there's peers, community health workers, and medical and behavioral health providers that go into the community to engage with those who are not accessing any type of supportive service and are likely unsheltered. So it's developing those relationships. It's a really important aspect of that. Street medicine builds off of that outreach model and then adds clinical services. And that targets people who are living unsheltered, who are likely not getting health services in other settings. Mobile healthcare is essentially a vehicle-based care that can move locations while still providing sort of the traditional healthcare setting. There's a lot of pros to that because you can move around to where the need is most significant and still have a location for someone to come in and receive the health services. Healthcare for the Homeless programs also continue to serve as models for the broader healthcare field in areas of medical respite and consumer engagement. Medical respite care is a term, both the term medical respite and recuperative care may be used interchangeably, but both provide the same service. It's acute and post-acute medical care for people experiencing homelessness who are too frail to recover from a physical illness or injury, but are not ill enough to be in a hospital. These programs provide short-term residential services coupled with supportive services and access to medical care, an incredibly important intervention in the places that are able to offer this. And consumer engagement is also something that is really integral to the work that we do. A consumer, for those that don't know what that term is someone who with the lived experience of homelessness that uses our health services. And you'll hear me use the term consumer, patient, client sort of interchangeably, but in this situation, we're talking about the consumer engagement. The engagement looks different for every health center, but consumers generally contribute to decisions in health center operations, quality improvement efforts, and they advocate for change in the wider community systems. Many times this looks like operating through a consumer advisory board, which many of the folks on this call operate or facilitate a consumer advisory board. Next slide. In terms of the value that HCA's program provides to communities, these are sort of the four buckets that we're looking at. So the first one, reducing reliance on emergency services. Without access to stable healthcare, many unhoused individuals end up relying on ERs for urgent care. So HCA's programs really reduce the strain on ERs by offering preventative, urgent, and follow-up care. This helps reduce avoidable ER visits, lowering healthcare costs, and then ensures that individuals receive care before conditions become life-threatening, which is usually what brings people into the ER. In terms of improving public health, unhoused populations are at higher risk of infectious diseases such as HIV, tuberculosis, Hep C, flu, which can spread to the wider community if left untreated. So HCH programs focus on infectious disease prevention, testing, and treatment, and protect both the homeless population and the broader community. In terms of supporting long-term stability, our programs address both medical and social needs, so such as access to housing, mental health care, substance use treatment, which helps individuals move towards stability and independence. Things like supportive housing and medical respite care are part of the HCA services that we provide, and this helps transition people out of homelessness into stable environments so they can receive ongoing care. And then the last one, bolstering economic and social benefits. I'll go through this a little bit in the next couple of slides. But this essentially, we provide early intervention and preventative care and reduce healthcare costs. This is mostly because we're managing chronic conditions, preventing disease progression, and again, reducing those ER visits. And I'll talk about that in a little bit in the next slide. This is important just as we're talking about sort of what's happening at the federal level to understand what the funding is for our services. So as this shows, Medicaid is the primary funding source for all ACH programs, representing approximately 1/3 of annual budgets. Beyond Medicaid, funding from HRSA represents about 1/4 of the revenue. And then for those that don't know what HRSA is, that's the Health Resources and Service Administration, which is under the U.S. Department of Health and Human Services. State and local grants make up about 1/4 of the funding, and then that's followed by private insurance, Medicare, and then other funding sources as well. It's really important to note when it comes to funding sources, it's a little bit different for some health centers, and it's dramatically affected by state policy decisions, such as expanding Medicaid coverage to cover specific populations, which we'll go over in a bit. Next slide. This is to give you an idea of our patient population. This is from 2023, what is called UDS data. This is information that is submitted to HRSA every year that shows the impact in the community. So in 2023, there's about 300 healthcare for the homeless grantees across the US, providing healthcare in about 4,500 service sites for nearly 1 million patients through 5 million clinic visits. It's a lot of numbers, but it sort of shows you the breadth of the work that we do. Most of our patients are at or below 200% of the federal poverty line, so low-income folks. About 2/3 of our patients identify as members of racial or ethnic minority groups, really highlighting the disproportionate impact of homelessness on communities of color. And then over half of our patients are also uninsured. We're utilizing Medicaid or Medicare, a point that will be brought up a little bit later as well. Next slide, please. Just to keep an eye on the time, I'm going to move through these really quickly, but this right here, in terms of how we manage chronic conditions, of the 1 million patients served, it gives you an idea of what the conditions that we're trying to address. So I'll just bring the attention down to hypertension. About 1 in 5 of the folks that we serve are dealing with hypertension, diabetes, about 1 in 10, depression or mood disorder, same thing, about 1 in 10. Next slide. And this shows our integrated care services provided. So these are all the different types of services and the utilization that we're seeing there, with the top being mostly medical care, but we also have dental care, vision care, behavioral health care, and then an enabling services, which usually gets people connected to other things outside of what's considered like a clinical service. So things like housing, translation services, outreach, so on and so forth. Next slide. This right here is important just to kind of look at what the clinical quality measures as compared to other healthcare or other community health centers. So healthcare for the homeless is also part of that umbrella of community health centers. HCH-funded health centers share a similar impact on quality measures when compared to all community health centers. So here, as you can see, access to prenatal care, cervical cancer screening, breast cancer screening, blood pressure control. We are on par with other community health centers as well. Next slide. This is the one I really wanted to get to because I think that this is really helpful if you're having discussions with legislators or just to have them understand what our impact in the communities is. So I'll point you to a couple of things here. In 2023, HCH programs provided about 25,000 jobs. So that's the actual number there. You'll see the breakdown in the table. They had an economic impact of about $4.5 billion in the communities and added about $543 million in annual tax revenues, both state, local, or all state, local, and federal. The economic impact is calculated by looking at the direct impacts from health center expenditures associated with operations, new facilities, and hiring, and indirect community impacts resulting from purchases of local goods, services, and jobs in other industries. Next slide. And then this is also super important too in terms of the savings to the system. So in 2023, HCH programs lowered costs by about 22% for health center Medicaid patients and saved Medicaid about $1.3 billion, saving the overall health system about $1.8 billion. That means that HCH health center Medicaid patients have lower use and spending when compared to non-health center patients, meaning that they have fewer visits, lower spending on specialty care, as well as fewer admissions and lower spending in inpatient care, which is a really important data point where we're talking about how we save money to resources, especially when we're trying to keep people out of ER. So the work that we do is really essential in the fight to prevent and end homelessness when we're addressing the health needs of those that we serve. And although I did not touch too much on this presentation, but housing is an absolute necessity when we want to truly mitigate the health impacts of homelessness and those that we serve. So housing is healthcare, something that you will hear us here very often in the work that we do. So I'm going to turn it over now to our panel discussion. This is going to be on the impact of HCH services in our communities. So I'd like to introduce our moderator, Rachel Biggs, which is our Chief Strategy Officer from Albuquerque Healthcare for the Homeless. So I'll have her come on, and then she will introduce the rest of the panel that they can come on as well. Thank you all.
Thank you, Natalie, for setting us up so well with that excellent overview. It is my great honor to introduce our expert panelists today. So I will introduce first Dr. Aislinn Bird, the Director of Integrated Care, a psychiatrist at Alameda County Healthcare for the Homeless. Dr. Bird, thank you for being here. Cynthia English, the lived experience consultant at Care for the Homeless in New York City. Cynthia, thank you for participating. Padmini Patty Mehta, the physician assistant at Healthcare for the Homeless, Houston. Thank you, Patty. Nice to see you. And Tamisha McPherson, executive director at Harlem United. Tamisha, thanks for joining us. Great. Well, we're going to start with a framing question for all of you. In 1 minute, I will go around and call on you. Could you tell our audience what your organization does and what drew you to the work? Dr. Bird, we'll start with you.
Great, thank you. I'm at Alameda County Healthcare for the Homeless, and we're located in the San Francisco Bay Area. Our hub is in Oakland, California. And we do quite a lot of things. We have multiple integrated care teams that really meet our patients wherever they are in the spectrum of homelessness. So we have 14 street health teams that cover all of Alameda County, providing medical care, behavioral health care, case management to folks living on the streets. We also have an extensive shelter health team that provides care to folks in the shelter. We have medical respite sites, an integrated care site in downtown Oakland. We also have an amazing and very active CAB, our Consumer Community Advisory Board, that really help show us the way, because working and listening to folks with lived expertise is just critical. And we also do a lot of coordination with cities, especially around weather emergencies and trying to mitigate the harm from abatements. And I got into this work because I really strongly believe that healthcare and housing is a basic human right.
Thanks, Dr. Bird. Cynthia, brief overview and what drew you to this work?
Hi, thanks for having me today. Well, I'm on the Consumer Advisory Board at Care for the Homeless, and I'm also a member of the Board of Directors. I have a long history of not only experiencing homelessness myself for over a decade, actually, but I was also a shelter specialist with the Coalition for the Homeless for many years. So I've been in and out of just about every shelter that there is up until I retired a couple of years ago. The reason that I was drawn to this work is not so much that I was drawn to it, but I think it was drawn to me. It wasn't something that I ever intended, but through my experiences with homelessness and then slowly starting to advocate for other people, I realized that there were so many people who were so traumatized and so terribly affected by all of the things that they went through leading up to their homeless situation and then going through the situation. They didn't know how to speak for themselves. And I found that I have no problem speaking out. So it just was kind of a natural progression in my life. And here I am. And I work with Care for the Homeless because I believe in the principles of Care for the Homeless, to provide health care for people who need it the most. I mean, everybody needs it, but I was street homeless for 10 years, and my only health care during that time was either the emergency room or literally jail. So I have illnesses today that more than likely are a direct extension of what I put my body through during that decade living in the streets. So, you know,
Thanks.
it,
Thanks, Cynthia. I think we're going to get more into that discussion soon.
yeah.
Appreciate it. Thank you. All right, Patty.
Hello, everyone. My name is Patty. I'm a physician assistant at Healthcare for the Homeless Houston. We are the community's only FQHC exclusively providing care for individuals experiencing homelessness and affected by homelessness. We have 3 clinic sites which serve as single access points, providing medical care, psychiatric care, addiction counseling, case management, social services, specialty care such as podiatry, as well as ophthalmology, case management services, social services, and also transportation services, specifically Project Access, which is our bus system. It provides free transportation to about 21 different sites throughout the city. We also provide care at 6 permanent supportive housing sites, as well as street outreach through our robust street medicine team. What drew me to this work is the opportunity to pay it forward and to be a kind neighbor. When I say kind neighbor, I don't necessarily mean just in proximity, but also in intention, action, advocacy. I was a kid in the 1990s who moved from South India to South Texas, and I was really excited about the new adventures and making new friends, quite frankly. Soon after, following the separation and divorce of my parents, I found myself in a single parent household, trying to navigate that way of life and all the plot twists that came with it. I quickly understood the value and impact of a kind neighbor, of an interdisciplinary team, of community, whether it was a school teacher who checked in on the quiet kid or the counselor who helped me navigate the lunch lines, the class schedules, eventually college tours and scholarship opportunities, or the manager of a local nonprofit organization who helped nurture and cultivate that sense of service my grandfather instilled in me and my parents instilled in me, or the pediatrician and the medical team who helped my family and I navigate the healthcare system. And the list goes on, right? But all that to say, I learned very quickly the power of being a kind neighbor, of an interdisciplinary team, a group of individuals unified in purpose with extraordinary backgrounds, skill sets, who work together to combine or connect the needs to the resources to bring healing, restoration, wholeness, empowerment, and also reconciliation and health overall. And I believe that's what I have the opportunity to do here at Healthcare for the Homeless Houston.
Thanks, Patty. Can't wait to hear more about your work. We'll move on to Tamisha.
Thank you. So at Harlem United, everything for your health is in one place. Currently, we have 2 brick and mortar clinics. We have a medical and dental mobile unit. We offer primary care, dental, therapy. We actually have housing, emergency shelter, transitional, permanent, and supportive housing, food pantry, sexual health, safer drug use. We have our adult day program and our healthcare navigation. So we have a lot of services to offer to our clients. And I would love to share that I wind up actually coming back into Harlem, because we're in the heart of Harlem, Central Harlem. 25 years later, I worked at Harlem Hospital 28 years ago. I'm going to say 20-something years ago. I don't want to give my age, but wind up coming back into working with the homeless population, and had no connection at the time that I wound up doing my master's in public administration, and the focus was on homelessness in New York, with connecting people to care who did not have any insurance. So now to be working in the field, and I have to honestly say things have gotten worse than better, and I received my master's degree about 20+ years ago. So it's a little scary where we are, that things are not even improving, they're getting worse.
Thanks so much, Tamisha. Appreciate it. All right, let's move into our questions. So this first question that we have, I'll start with Patty. As a provider, what unique challenges do you face when delivering care to patients experiencing homelessness? And how does the HCH model help address them?
Some of the challenges I see pretty consistently on a day-to-day basis would include competing priorities, right? So you have daily survival needs such as food, shelter, safety, which often take precedence over health concerns. For example, I had a patient not too long ago who was new to me, new to the clinic, but with chart review, multiple ER visits, uncontrolled hypertension, type 2 diabetes. And while the patient was waiting in the exam room, you could tell he was pacing, he appeared anxious. And before I even had the opportunity to introduce myself, the first thing he said was, "If I don't leave this building in the next 5 minutes, I won't eat for the rest of the day." He wasn't going to have enough time to complete the medical visit, travel across downtown Houston to get to the local soup kitchen in time. So this was truly an opportunity to tailor the care to the goals and priorities of the patient. So at that moment, what was important to the patient? Food. So prior to the medical visit, we had the opportunity to introduce the patient to the social services team who extensively reviewed food resources with the patient in the city. So patient was empowered with the information on where to get food that day and every single day of the week, right? The other challenge I would see is limited support systems. Lack of family, community, and social support. And it all impacts mental health, right? Leading to poor health outcomes and increases the difficulty in navigating resources. I tend to ask my patients who I meet for the first time, "How did you hear about us?" And most will say, "A buddy of mine told me," or "I was at the bus stop waiting for the bus and I overheard." Now, the HCH model specifically provides opportunities to anticipate the needs for our patients and also to circumnavigate the barriers to provide low barrier access to care, whole person care. The model allows us to be proactive, right? It's team based, patient centered, and it serves to connect healthcare with all the resources: housing, behavioral health, social services, and so many more, which we've listed.
Great, thank you so much. And Dr. Bird, same question for you. What unique challenges do you face when delivering care to patients experiencing homelessness? Tell us a little bit more about the HCH model.
Great, thank you. And I fully agree with everything that Patty just shared. Another challenge that we see every day is the challenges with follow-up, especially given the increased rates of encampment abatements that we're unfortunately experiencing in Alameda County and across the nation. And so our HCH model, and especially our street health team, really address this by building trusting relationships and really knowing our patients. We also are in pretty good communication with the cities. And so we usually know when an abatement is going to happen. And so then we'll go to that encampment and provide extra support in the days beforehand. Make sure everyone has naloxone because you are at a higher risk of overdosing after an abatement. Make sure we know where folks are going to go. Ask if we can follow up in that place. We also, with our street health model, is we have a very consistent outreach schedule. So we're always in the same place every week. So our patients know where to find us if they do move away from the area. And again, building those really long-lasting, trusting relationships. I lost touch with a patient a couple of months ago after her encampment was abated, and she just called me yesterday and shared that she had memorized my phone number, and it was only my number and her mom that she had memorized, which was just so touching. So it's all about building trust and deeply respecting our patients.
Thanks, Dr. Bird. And you kind of alluded to this already, but how does the HCH framework support harm reduction and long-term recovery?
Yeah, great question. And harm reduction is part of everything that we do. So the harm reduction philosophy, kind of like deep love and respect and accepting that people do use substances. Our HCH model is seeped into the philosophy of harm reduction. That's why we go and meet people where they're at, whether in the streets or in the shelter, or if they are moved into permanent housing or transitional housing, med respite. So really meeting our patients where they're at, where they are physically, but also where they are in terms of their stage of change. Really respecting that our patients know what's best. So I'm not going to push my agenda on my patient. I'm really going to listen to see what their goals and priorities are and respect that before talking about other things that we have to offer. But then it's the philosophy, but then it's also just the practical skills of making sure folks, they know how to use safely, but it's also part of our outreach supplies. So safer injection kits, fentanyl test strips, condoms, all those things. So harm reduction is a philosophy and also practical skills that we utilize every day.
Great, thank you. And Patty, how do you effectively address the primary care needs of people experiencing homelessness? What strategies have proven successful in promoting consistent long-term engagement with healthcare services?
I really believe it's the idea of understanding that the patient is the expert, right? The patients are the experts in their lived experiences. So it's vital to incorporate the data-driven best practices with our patients' lived experiences to build that foundation of trust and collaboration, right? And it's also to see the person, not so much the diagnosis, not so much the ICD-10 code, but what are the goals of our patients? What brings them joy? What do they find meaningful? What gives our patients strength? And what's important to them? What are their priorities? Many of my patients, I've had so many conversations where they want to reconnect with family. They want to start working or write a book, perform their poetry or music in front of a crowd. And in addition to understanding our patient stories, I find it to be extremely crucial to utilize the interdisciplinary team, right? The team members encounter patients in such a different capacity. I might see a patient 30, 45 minutes every 4 weeks for a follow-up visit versus our chaplain or counselor or therapist who may see the patient more frequently. So it's important to make sure the entire team is aware and empowered with the resources that we have for our patients. And I had a patient just the other day say, hey, my counselor was also talking about PrEP. Can we talk a little bit more about that today, right? So also thorough introduction of services available, generally at the first visit, but at times that could be overwhelming, right? Our patients may not be able to identify all the needs at once, but they remember sometime in the future, maybe 3 months, 6 months down the road, I remember someone from Caroline Street Clinic telling me, if I need this, this is where I can go. If I need that, that's where I can go. So it's truly the idea and practice of empowering patients to take the lead.
Thank you. Wonderful. All right, we're going to turn it over to Cynthia. We'd love to hear a little bit more about your experience with healthcare for the homeless services. And if you could help us identify what's different for you compared to other healthcare settings in the HCH setting versus other healthcare settings. And then if you could also touch on what kinds of support have made it possible for you to access care consistently, even when facing housing challenges.
Absolutely. Healthcare for the homeless services really had a positive impact on me. One of the drivers for my long-term homelessness was severe mental illness. So, I was not making good decisions all around the board. I wasn't capable of it. And going to, say, the emergency room for medical care, you get that limited amount of care, but they don't really have the desire, or you feel that they don't really have the desire to be working with someone in your situation. And I think anybody who's ever been to the emergency room and seen a homeless person there can feel the difference in the way that homeless person is often treated versus everybody else in the room. For me, I found that because the people providing these services were targeting us as a community and wanted to work with us, the attitude was totally different. It was warm, it was welcoming, it was I see you and I understand that you're in this situation. I didn't feel like I was repulsed, they were repulsed by my presence, because I wasn't clean, I wasn't, sunny and bright. And it while I was going through my challenges, I was fortunate enough to be in, when I finally went to a shelter that had co-located services, like care for the homeless. And one of my diagnoses is agoraphobia. So you can imagine being homeless and having to travel around the streets of New York from neighborhood to neighborhood trying to find care. that I could trust. It wasn't happening. I couldn't get on a train. I couldn't get on a bus. And so if a place was not within walking distance, I wasn't going. You know, new situations, new environments, and then every time you go someplace, there's a different person there. When you're deeply traumatized, one of the things that you need is consistency. Another thing that you need is a sense of safety. And for me, that sense of safety only came through familiarity. So being able to see the same people all the time, not having to travel, you know, from borough to borough trying to get care, it helped win my trust, and it helped give me the will to be consistent in getting care for myself because I was in a safe space. I felt I was in a safe space. And what was the rest of the question?
What kind, you already touched on that, the kinds of supports and the care that you received and what made that different in an HCH setting. So I'd like to turn to the policy discussions. What would you want policymakers or the public to understand about your journey and how HCH programs made a difference?
You know, my journey was unique only to me. I'm one of millions of people who have gone through or are still going through homelessness in this country. My challenges were not unique at all. And they need to understand that this is not a selective kind of issue. You know, it can happen to anyone at any time. And we all need to have that safety built into this system so that we don't keep losing lives. You know, people don't keep dying prematurely. We were not meant to be unhoused, and we were not meant to be without consistent care. That's for every human being, you know. And there's also the component of Medicaid, because now I'm in a position where my Medicaid has been cut off because according to the government, I get too much money in disability. And so now I'm responsible for all of my co-pays and everything. So I'm only receiving half of the care that I should, except for Care for the Homeless's community health care services, where I don't have to worry about co-pays. I don't have to worry about if I have Medicaid or not. So this allows me to continue the continuity of care and keep getting the services that I need so that I can stay as healthy as possible.
Thank you so much, Cynthia. And that's a great segue into our Medicaid discussion with Barbara later. But I am going to turn it over to Misha now to talk about some of the biggest policy or funding challenges facing HCH programs right now. So hearing Cynthia talk about the importance of access to healthcare and the care that she received at Healthcare for the Homeless in New York City, share your experience and what you think are the biggest policy or funding challenges right now.
Sure. So what Cynthia spoke about, that's where some of our major challenges are. So yes, we are, I would say, FQHCs, especially 330H programs. We are a place that people come to that may go to a private practice or go to a hospital clinic that's not a FQHC and maybe turned away because they don't have any Medicaid. We don't turn patients away for inability to pay. So we provide the same high-level care of services to that patient. But on the other end, which I'm going to talk about, is some of the challenges that happens on the FQHC end. So one of the big ones we're facing now, it's huge, is the New York State Medicaid is under attack, significantly cutting reimbursement for those who are insured. That affects how we try and offset some of the funding levels. Another big policy and funding challenge for us is our 340B program, which at the end of the day is still not stable. We know what we will receive more than likely for another year, but that particular funding is huge for every FQHC, because if that money was to go away, it would be very hard to continue offering these services, because the funds that we receive from our 340B program helps cover the cost of the medications that our patients need. Our HRSA grant is a big one for us. The HRSA grant amount is limited, and we've had limited increases over the years, and I can speak for Harlem United. Aside from getting a supplemental grant that sometimes rolls up into your main grant, the increase or even supplemental funding still doesn't cover the cost to run the health center. So we depend on Medicaid and billable visits and other types of grants. We continue to be challenged on a daily basis with our health insurance companies. So we bill, and the biggest challenges that most healthcare for the homeless programs are challenged with would be our denials, because the patient may have gone somewhere else prior to coming to us. PCP issues, which is the primary care provider issues. So we still see the patient, we don't turn them away. A big area that we have to deal with right now too is credentialing, the delays in credentialing, which affects FQHC cash flow. And the safety net is another area that I don't know if there's much we can change or do, but the safety net doesn't always cover or add up to the loss of revenue that we actually, we'll see the patient up front, but that the funds come in a year later. But we have to pay people every 2 weeks.
Thank you. That's a great overview of all the complexity of the current situation right now. How would you say HCH programs are adapting to meet these evolving needs, especially of our patients and communities that we're serving right now?
So we are seeing currently a higher level of acuity that require higher levels of care than other, I would say, healthcare facilities. Much of the support service care needed for our clients are not reimbursable, and implementation of future requirements to keep insurance coverage will add to the assistance our patients need without a way to pay for those staff and services. It would be useful for insurers to better explain what is covered and not covered. It leaves providers and health centers in a difficult position to explain insurers' decisions and policies. And I can give you an example. We actually, you may have a contract, but a provider uses a diagnosis code that could be in the contract. For some reason, it's denied for whatever reason. And again, and when I say that, it could be the provider is not in, could be in network, and not set up on a credentialing end as a agency from an individual provider. We are pushing that facilities should be set up across the board, that we shouldn't have to worry about this provider and that provider, especially as a FQHC, which is a little bit different from, private practice or a hospital clinic that's not a FQHC. We treat all patients regardless of insurance plan and or reimbursement for insurance companies or self-pay amounts received. And we will continue to meet patients in the community where they are, but at the cost or loss for many agencies.
Great. Thank you so much, Nisha. All right, we're going to move into a little bit of a lightning round, and I'm going to ask a question of everyone. So we'll have 1 minute each for these questions, and we'll see how many we can get through before we move on to our presentation from Barbara. So for our first question, what would you say is the one thing that needs to change at the system level to improve healthcare access for people experiencing homelessness? Tamisha, we'll start with you.
I would have to say we need to continue fighting and rallying, pushing for rate reform. It's really been challenging for smaller FQHCs, especially from the day-to-day seeing a patient, but actually looking at the amounts of money that we're not receiving for so many reasons. Right now we're facing Medicaid cuts, but if they're cutting the rates and we still have not received an increase from Medicaid for over X amount of years, I would say over 20 years, I think it's 22 years, it's a long time. That is one of the biggest challenges that we're having right now.
Thanks, Tamisha. All right, Cynthia, same question for you. What would you say is one thing that needs to change at the systems level to improve healthcare for people experiencing homelessness?
Well, number one, we need to make sure that these providers are being paid properly. I think that without the proper reimbursement, the services cannot continue. And for people like myself who have different types of diagnoses that may prohibit us from being able to go into a doctor's office all of the time, loss of things like telehealth because of lack of reimbursement, it has to change. They've got to fix it. They've got to fix it, because if we don't see our providers, our health declines. Our health declines, we lose our lives.
Thanks, Cynthia. So lots of great reform conversations here. Dr. Bird, let's go to you next. What would be one thing you would change at the systems level?
I'd like for us to continue to really look at and think about our old medical system that we have created. Like, so inspiring to hear other people's systems of care with more, drop-in appointments, more same-day appointments, clinics that don't require an ID or health insurance, so people can, when they're ready, can really receive care right away. Telemedicine is amazing. I fully agree, Cynthia, that needs to continue. And our medical model was really set up for the convenience of providers and for, providers, and really not looking at the unique needs of people experiencing homelessness. There's some amazing things going on, and I still think there's a lot of room for creativity and providing the best medical care and services to folks experiencing homelessness.
Great, thank you. And Patty, what would you change?
I would say increase the importance and the understanding of the value and need for low barrier access to care, meeting individuals where they are, right? Both literally and figuratively. Housing, for example, we know that housing is healthcare. My firstborn tendencies are pretty strong when it comes to checklists, but can we utilize checklists to monitor progress as opposed to determination of eligibility for services? We can provide robust medical care, but what happens to our patients after that medical encounter, after that medical visit? In what environment are patients going to carry out the medical recommendations or the plan of care? Many of my patients who are residing at a PSH site, at a permanent supportive housing site, are more likely to be engaged in the services. The continuity of care is more likely versus my patients who are experiencing street homelessness. So the idea of consistently investing in housing tailored to the patient's needs, right? The specific needs will improve health outcome and overall reduce cost. We know this, right? The idea of housing first versus treatment first. We know that housing is the platform for recovery. It's the idea of creating that safe and stable housing, which ultimately will end the cycle of homelessness. And truly, housing is the prescription.
Great, thank you. Wonderful. We're going to end with a policy question before we move into our policy conversation. So for all of you, we'll go around. If you could send one message to healthcare leaders or policymakers about the value of healthcare for the homeless programs, what would it be? And what do you wish they knew about this work? In 1 minute, we'll go to Cynthia first.
I wish they understood that this work is vital. This is not an aside, This is not just a project. There are real people whose lives are shortened or endangered because they don't get proper, consistent medical care in, as everybody's saying, a low barrier kind of way. And they really need to step it up, because it feels like we're trying to empty the ocean with a teaspoon, and that we're just gonna keep going and hope that things get right. But they're not gonna get right until we're all collaborating and we're all in the same frame of mind. So I wish they would understand that.
Thanks, Cynthia. Dr. Bird.
Similar to what Cynthia was saying, is that we are in a housing crisis across the nation. there's more folks experiencing homeless than any other time. And like was mentioned earlier, the life expectancy of someone experiencing homelessness is 20 years less, which is still shocking and saddening and disgusting to me. So until we fix the housing crisis, we absolutely have to meet patients where they're at, provide high quality medical care, case management, behavioral health care, really where people are at. And healthcare for the homeless has an amazing history and track record of providing, the best practices of this really unique, creative way of meeting people's needs and saving lives.
Great. Thanks, Dr. Bird. Patty.
I would say the message would be, I've always asked myself, is this compassionate work? Yes, it is, right? Is this also cost-effective, evidence-based, and essential? And achieving high health equity? Yes, also yes. So it's the idea of understanding the HCH programs having a positive impact on so many different levels, individual, community, cost. And as mentioned earlier, the 298 HCH programs save nearly $2 billion to the overall health system, right? So it's the idea of having the privilege of anticipating the needs of our patients experiencing homelessness and providing the resources at single access points. And the fact that we're able to do that, that truly, truly is such a privilege. And as a clinician, I understand providing high quality patient-centered care is really a thread in the fabric of caring for the whole person. And HCH programs, I've seen it time and time again, value the power of collaboration, right? Where we're able to connect housing with healthcare, behavioral health services, substance use treatment, social services. So it's very much providing that whole person care at a single access point.
Great. Thank you. And Tamisha, we will end with you.
Sure. So my take on this question, housing is healthcare and leads to empowerment and progress at FQHCs and especially 330H grantees. Remember to look at a patient and take a holistic approach. External factors like a person being unhoused or underemployed can negatively impact their health. The increasing number of patients and clients that move on with stable care. For example, our patients also in supportive housing that may mean improving their health so they are now able to move into more independent housing or stabilizing their health so they can explore employment and educational opportunities, which is something that, I don't think outside of our 330H health centers, I don't know if clients have that connection with their provider and other services all under one umbrella, and we're able to do that.
Great. Thanks, Tamisha. Wonderful. Thank you all so much for participating in this panel discussion. We still have 15 more minutes after this next presentation to get into Q&A, and so we'll hear from our panelists again. Thank you. Please keep sending your questions in that Q&A box. If you haven't done so already, you have some time as Barbara is presenting to think about your questions and get them in, and we'll bring our panelists back for Q&A after that. And now it is my honor to introduce Barbara DiPietro, the Senior Director of Policy at the National Healthcare for the Homeless Council, to give us an update on the federal landscape and threats to healthcare for the homeless programs. Thank you, Barbara.
Thank you, Rachel, and I appreciate being part of this discussion. I think this is so valuable based on where we are right now, particularly with things that are happening at the federal level that do pose real threats to all of the services, the model of care, and frankly, the Medicaid coverage that our panelists have just talked about. If we can move to this first slide, want to just talk about where we are right now. So there's a lot happening on this slide here, but just if you look at the graph on the left, getting a sense of what's the insurance sources for many of the patients that we serve. Healthcare for the homeless serves 1 million patients across this country every year. And overall, on average, 55% of them are on Medicaid, and we've got a 28% uninsured rate. Now, this varies widely by state based on state decisions, But you'll see here, in comparison to the US general population, Medicaid is especially important for us in the healthcare for the homeless field. And it's also important to really continue to address the rate of uninsured that we have, both from people who are in states that have not yet expanded Medicaid. So we call those non-expansion states. And so again, you'll just see real disparities here, but this is why Medicaid is so important. Now, shifting to the graph on the right. Now, Nathalie had talked about funding sources in her discussion, so just wanted to come back and touch on this point again. When we look at how our healthcare model is financed, it's vastly different based on whether your state expanded Medicaid or did not expand Medicaid under the Affordable Care Act. And you'll see here that where Patty is in Houston is going to be very different than where Rachel is in Albuquerque. And again, Medicaid is a primary funding source for HCHs in the 40 states that have expanded. And you'll see that ongoing grants, and BIPIC is the Bureau of Primary Healthcare, and that is the federal agency that gives us our health center grant funding. That is incredibly, disproportionately even important in non-expansion states, which continue to have all of their work primarily grant funded. And you'll see here that's either a mix of federal or non-federal grants. So just want folks to appreciate the volume of people that we have on Medicaid, and then the volume of revenue that funds our services, and frankly, that pays for our staff to be able to deliver the care that we provide. Next slide, please. And so one of the things that I want everybody to appreciate is you may have been hearing in the news a lot about the big, beautiful bill. And this is the budget reconciliation legislation that's currently in the Senate and is marked for fast track to be signed by July 4th. So we'll see if that timeline holds. But really, in order to pay for administration priorities, there's been an order to cut the federal budget fairly significantly, and specifically looking at cutting $880 billion from the Medicaid program over the next decade. So you'll see here that overall, the provisions in the big, beautiful bill will take away health coverage from 16 million people. Over half of those folks will be anticipated to come out of the Medicaid program, so falling off of the Medicaid program. Right now, there's about 72 million people in Medicaid, and having 8 million of them fall out of coverage is significant for both the care that they need to receive, as well as the financial stability of our healthcare system. Next slide, please. And so I want to just do a deep dive here, a deeper dive anyway, because we just have a moment to talk about some significant policy changes. So in the big, beautiful bill, here are the Medicaid changes that are going to be most impactful to unhoused people. There's been a lot of discussion about the work reporting requirements. I'll talk about that just here in a minute. But also particularly difficult for people experiencing homelessness is an address verification. How do you verify something that you don't have? And if that verification is required in order for you to continue getting Medicaid, then I worry that address verification through no fault of their own, people will fall out of coverage. Citizenship verification, again, we already have many of these checks and balances in place to ensure that people who are eligible for Medicaid are enrolled. But some of the onerous documentation requirements of the new bill really call into question how many US citizens are not going to be able to produce or prove their citizenship because they don't have a birth certificate, even though there is no doubt of their citizenship status. So again, the paperwork and the verifications are really what's going to trip people up. And then here, one of the provisions that really is a concern is very frequent eligibility checks every 6 months. And so on top of monthly work reporting requirements, regular address verifications, and then ongoing eligibility checks every 6 months, this is a recipe for massive coverage losses. There's some other provisions here. There's some penalties to states for using their own state money to cover non-citizens, even those that are legally present. There are provisions for significant out-of-pocket costs in order for people to access care. And I don't know about you, but $35 is not nothing. And so I can't imagine asking our clients to pay $35 to access care each time they need to engage. That's just, again, going to mean that people don't access care. And then it prohibits all gender affirming care and frankly slashes the retroactive coverage that many providers depend on. So when we get someone that we know is Medicaid eligible, we're able to enroll and deliver services right away while their coverage is being determined. And then we're able to bill for those backed services. But instead, this is going to prohibit us from being able to recover reimbursement for services that we've already provided to eligible people. Again, these are just all barriers to care that are being built into the new legislation. So I've talked a little bit about this. And really, this is about the paperwork. This is about bureaucratic red tape that's being layered into a system where we should be removing barriers and making eligibility easier to establish, not harder. If we can go to the next slide, we can talk a little bit deeper about work requirements because this has been getting a lot of attention. One of the things that we just do need to address out front is that work requirements sound good. They sound like good policy. American culture is very work-based. But let's take a look at the reality of work requirements. The systems are expensive. The goal is to drive loss of coverage. And ironically, they don't increase employment. It's not about increasing employment. It's about pushing people off the system. And if you can see in this graph on the right that we have over the last 10 years in states that expanded Medicaid significantly reduced our rate of uninsured. We have cut it over half from 51% right before the Affordable Care Act kicked in to now at 21% uninsured for people in expansion states. Now, again, we still need to work on that, but that is tremendous progress. It's at risk of being undermined by, again, this big, beautiful bill. Next, please. Just want to also talk about the added services that states have put in. So this is going beyond the core minimum services of Medicaid to really think about how can we use Medicaid in ways that support all of this work. So tenancy supports, you can see here, many states have added supportive services and supportive housing. That's critical. Next slide, please. And we've also seen a number of states, almost 20 states now, have added or in the process of adding medical respite care into their Medicaid programs. Again, this is a way of extending value-based, cost-effective care that increases the quality of the services that we already provide. Next slide, please. And so the decision-making to states and a lot of need for filling funding gaps to states. And there's a lot of, it's just unclear how states will respond. And it's reasonable to expect that every state is going to be in a different situation. So how they're able to absorb these funding cuts and what decisions they'll make in response, that's remaining to be seen. But we do anticipate that states are not going to be able to pick up all of the funding here that's possible. And so, again, we anticipate that states are going to be cutting eligibility, cutting services, particularly for most vulnerable folks. Next slide, please. And so what does this really mean? And I just can't be clearer here. When patients lose insurance, providers don't get paid. We don't have the revenue to be able to continue meeting our staff. Tamisha said, we've got to pay our staff every 2 weeks. If we can't make that, then staff lose jobs. If we don't have the staff and the money to serve this, then services end. We have to close clinics. And this is where people can't access care. This is where medical debt rises, and this is where people get sicker. And Cynthia said it earlier, we weren't meant to be homeless. We weren't meant to be without healthcare. And yet this specifically will lead to many people's death. And I'm not just being dramatic there. The Annals of the Annals of Internal Medicine did a study showing that there will be 16,000 deaths per year because of the provisions of this bill and taking Medicaid away from all of these folks. And there's also been an assessment by Commonwealth that 1.2 million jobs will be lost in the next several years because of the provisions of this bill. Just real quick, if we can go to the next slide before I wrap up. Just want to mention also, in addition to the Budget Reconciliation Act, we also have fiscal year 26 budget that's also starting to move through Congress. And this has a number of additional cuts to the programs, grant funds, and other services that we rely on to complement Medicaid. So combined, this is really going to be very hurtful for healthcare for the homeless programs, as well as the patients that we provide services to. I know we're running low on time. I covered a lot of content really quick. If we can go to the next slide. What can you do about all of this? So here's a QR code. We put out a monthly mobilizer and action alert to make sure that people are up to date on what's happening. But we need folks to be calling their federal and state policymakers. We need folks to be telling them to vote no on the big, beautiful bill. We have to reject this narrative of deserving versus undeserving poor and people who deserve healthcare and people who don't. That's just not a human rights perspective. And we need to connect the issue of homelessness to Medicaid and these cuts so people understand why this is such a problem. And then I know the next slide here, we were also going to be putting up a poll. I know we're running low on time. We're going to put up a poll so that we can get a sense of what advocacy efforts interest you. And so if we would love to hear, like, what kinds of things are you interested in? And you can choose more than one if you like. But sharing your story or calling your representatives, setting up a meeting, even better with your representatives, a site visit, even better. Maybe you're unsure, but you're interested in getting more information. We would love to just hear more from you on what this looks like. And again, I'm just kind of talking through this while some of the responses roll in. And then I will say that I thought, very good, here we go. Over half of you are interested in calling and emailing your congressional representatives. Fantastic. A quarter of you setting up meetings or a site visit. Another half interested in getting resources. So appreciate all of this. And I appreciate this discussion. And again, just wanted to slide in some of the things that are happening right now that are very critical to this. So thank you for this and adding this perspective into this discussion. And I'll turn it back over to Rachel.
Thank you, Barbara. As always, impressive how much information you can cram into a short presentation. That gave us a lot to go on for questions. So we're going to go right into our Q&A session and really appreciate everyone sending in questions ahead of time. So we'll go to some of the questions in the chat box and then also questions that we received ahead of time in the registration. Our first question I'm going to direct towards Cynthia. Are there any pieces of practical info or wisdom that homeless people wished social services and healthcare providers knew to better serve the homeless community? And I can repeat that.
Yeah, I think one of the main things that I hear over and over and over again is that people who are experiencing homelessness or, in whatever part of the journey they're in, oftentimes they just don't feel seen, they don't feel heard, and they definitely don't feel equal. We tend to feel like others all the time. And it would be nice if that otherism could stop and we could just be seen as people who are in need of services.
Thanks, Cynthia. So well said. All right, let's go to Patty. How do you measure success in this work? And what does impact look like beyond traditional metrics?
Success, I've learned, is truly measured in human connection, right? Establishment of trust, reduction in barriers, and also having our patients engaged in services, actively utilizing the resources. Success is very much patient-centered. How are we addressing barriers? How are we eliminating barriers? Quality metrics are vital, right, in providing high-quality care. However, does the patient feel safe? Do they to a patient I had yesterday, smiling ear to ear, saying, have you seen my blood pressure? Have you seen how far we've come in the last 6 months, right? It's the idea of our patients overcoming those barriers with the resources provided for them, where they're able to come to their follow-up appointments, the continuity of care is well established. Or, hey, guess what? My daughter called me yesterday and I told her I'm doing okay. So success is truly understanding the transition from survival mode to living with a purpose.
Great, thank you. Barbara, turning back to the federal landscape, what federal policies have most improved the ability for unhoused individuals to access healthcare?
Medicaid itself, the expansion of Medicaid was the single biggest benefit that we got in our world in decades. And so again, that's part of the reason why we are so worried about that going away. So again, I can't emphasize enough the need for us to retain health insurance coverage for those that we serve.
Great, thank you. Dr. Bird, how can we help a client when they say they don't want help? What advice do you have?
Excellent question. I think, again, showing up with love and kindness and being consistent. First asking for consent if it's still okay if we, meet them where they're at, and also really learning what their goals are. If it's just wanting a hot cup of coffee or a bagel, that's great. Like when I go out with our street health team, there's many patients who I'm just going and every week provide a cup of coffee or just sit and chit chat for a bit and really continuing to slowly build that trust and understanding and very slowly understand what their goals are. And then together with the team and, the patient is always the head of the team, figuring out like, what are there ways that we can help support them in reaching their goals? But it takes time and it takes patience and love and respect. So it's not on the same timeline as like a regular clinic. And that's one of the really amazing things with the Healthcare for the Homeless model is that we have that flexibility to really meet our patients where they're at.
Great, thank you, Dr. Bird. All right, Tamisha, this one's for you. We talked a lot about cuts to programs. So if there are cuts to any of these essential programs at the federal level, how can agencies that are designated for these kinds of services continue to exist and even expand services in this environment?
I think one of the biggest things we're looking at is other types of funding outside grant funding. So fundraising, looking at foundations that had some success, I would say, in the last few months of looking at foundations and having different type of fundraising events.
Great, diversifying funding. All right. Thanks, Tamisha. All right, I think this is a good street outreach question, and I'm going to hand it over to Dr. Bird to answer this question. So this question was, is there a way for partnerships between nonprofits, government entities, and faith institutions to create sites where people experiencing homelessness can access care outside of healthcare facilities? How many faith-based institutions, might be in these areas of high need, and so there could be an opportunity for co-location of these sites. Do you have anything to add about what street outreach looks like and how we partner with different organizations?
Yes, absolutely. And I really appreciate what Patty was saying. It's all about partnership and working together. So we work very closely with different nonprofits, with different advocates. There's community harm reduction folks that are providing needles to folks on the street. And it's all about having a coalition of everyone that is providing this care from different perspectives. In Alameda County, we'll have wellness fairs. We just had one at one of our largest encampments where different organizations come and we have food, and it's pretty fun, but it's also a place where people can get access to healthcare, behavioral health. We had our partners who do advocacy and lawyers and SSI and those benefits there. But also a lot of grassroots, like I said, our advocates and folks doing a lot of the work just right on the streets. So it's such a critical time that we build those partnerships and really unite, because we all have the same goal of providing quality care and making sure folks on the street are as healthy and happy as possible until they can get housed. And even then, continuing the care. And yes, into faith-based organizations, everyone needs to be involved. There's space for that.
Great. And a follow-up question, this is another question that we just got. Are there services for people that aren't in shelters or a place of their own, or are there outreach programs that help get people that are homeless into shelters or into housing? How does that look, that kind of street to housing, street to shelter? What does that work look like from your perspective?
Yeah, excellent question. So homelessness is a spectrum, like I mentioned. And so we have our street health teams where we meet folks in encampments, but also if they're just living alone on the streets. And really, we do housing navigation and problem solving. So is there a family member that they could live with? And if not, are they interested in the shelter system? We do have limited shelter beds here in California, and shelters aren't necessarily the right fit for our patients. So really understanding like what is available in the community, and then also figuring out like what the best housing situation would be for our individual patients. We have something called coordinated entry here, which is like a one spot where folks can go into the housing waiting list, and making sure that folks are document ready. So they have all their documents ready and set. So when they are called up for housing opportunity, that we can jump on it right away. Again, also making sure that we know where folks are. So if a housing opportunity pops up, we can connect with them again right away and jump on that opportunity. So it's one of the biggest things that we do on the streets and in the shelter. And also just, again, really respecting our patients, that what housing is available for them right in that moment might not be the right fit, and really respecting their choice not to go into a shelter if that's the case, but still working with them for their long-term housing goals.
Great. Thanks, Dr. Bird. All right, Patty, this question is for you. So if we see funding for prevention and treatment of infectious diseases such as flu, COVID, tuberculosis, if that funding is cut, what do you think is the outlook for those cases? Do we expect them to rise? What does that look like specific to the healthcare for the homeless population without this funding?
That's a great question. I mean, truly, the impact is just absolutely terrifying to think about, right? It's very much a public health crisis. And it's the idea of being as creative as we can and collaborating with our community partners to kind of anticipate any changes, but also patient empowerment, right? How can we talk to our patients about the impact of preventative healthcare and also to advocate for that? It's the idea of, could we be 10 steps ahead of any negative outcome, and having those open, honest conversations to prevent any sort of public health crisis.
Great. Thanks, Patty. Cynthia, we have a question in the chat for you. It's from a physician, and the physician says, I find it very challenging to have patients follow up. The question is, as a patient, what made you follow up for your medical visits or care? What helped with follow-up?
What helped me with follow-up was, first of all, feeling safe, feeling comfortable, and not feeling like they were trying to rush me out of their office, speaking to me, not dumbing things down as if because I was homeless, I couldn't understand things, and just really feeling respected. And then seeing the same person for the most part each time I went in, which today is, it's a lot more difficult. Retention is a difficult thing these days. But it was just all of those humanizing little things that other people get when they go to see their doctors and their practitioners, and they're not homeless. It feeling like I used to feel before I became homeless when talking to a provider.
Great. Thanks, Cynthia. And I have one more follow-up question on that. It's for Patty. How do you build trust with patients who may have experienced stigma or poor treatment in the healthcare system before? So hearing Cynthia describe her experience, what do you do as a provider to build trust?
It's the idea of small, consistent, reliable behavior, right? And intentional actions to help create that foundation of trust, which, we've mentioned earlier, takes a period of time. And also keeping the environment as predictable as possible, helping the patients identify their goals, helping the patients connect the needs to the resources, and also advocating for our patients. Is it navigating through barriers? Is it transportation, completing paperwork, connecting with housing, connecting with resources in the city, and also changing vocabulary, right? Using trauma-informed, anti-stigmatizing language in conversation as well as documentation. It's survivor of abuse versus victim, or living with substance use disorder, or individual struggling with treatment plan. Urine is positive for versus it being dirty. And it's also kind of building that into a day-to-day practice. That way our patients can see that and experience that, and also reframe their vocabulary, reframe the idea of saying, how could I prevent this negative self-talk? And truly, the idea of practicing trauma-informed care, cultural humility, which allows for that solid foundation of trust.
Thanks, Patty. What a great way to end. Really appreciate all of our panelists and our presenters for being here today. Great conversation. Really appreciate your time and your wisdom. I am honored to be able to hand it over to Bobby Watts, the CEO of the National Healthcare for the Homeless Council, to close us out. Thank you all.
Thank you. Can you hear me?
Yes.
Okay, great. Thank you. Thank you very much. Thank you, George, Natalie, Rachel, and everyone at Care for the Homeless, as well as all the other panelists that are also members, I'm pleased to say, of the National Healthcare for the Homeless Council, and my colleague at the Council, Barbara DiPietro, for a wonderful presentation. We've been treated to a panel and presentation that presented the perspective of advocates, clinical providers, administrators, and people with the lived experience of homelessness. I was asked to share one or two things that I hope you take away from this webinar. And so I'd like to start with one of them by sharing a quote from Susan Nybacher, the founder of Care for the Homeless and also a founder of the council and my mentor when I worked at Care for the Homeless. And her quote is, "Homelessness is the result of the failure of almost every one of society's systems." We don't have mass homelessness on the scale we do in the richest country on earth, solely as a result of individual weaknesses. As a society, we have failed to meet the basic human needs of our residents. That is why your involvement in advocacy to make systems better, to keep them from becoming worse, is more important than ever. We can make a difference, and we have to make a difference. The second thing I hope that you take away is that the success that we see in the Healthcare for the Homeless programs is largely based on the understanding that there is no such thing as a service-resistant client. There are, however, client-resistant services, and Healthcare for the Homeless has adapted services to make them responsive to the needs of people without homes by going to where they are, by co-locating services, by emphasizing harm reduction, practicing whole person care in interdisciplinary teams. This is a hard problem, but we have shown that it is solvable when we meet clients where they are, when we listen to them and take their suggestions into the design of our services. I really want to thank everyone also for attending. And in conclusion, I want to say there is a feedback survey for everyone to fill out once the webinar exits. We want to hear from you so we can have more webinars and we understand what works for you, what you're interested in seeing. So we truly appreciate your participation. If you have to run to a meeting immediately now, please keep the browser open and then come back after your meeting and fill it out. We will email the slides and the recording and other resources to everyone who is in attendance. Thank you for attending this webinar. I hope you all have a wonderful rest of your day. Thank you very much.